First of all, I wanted to thank the organizers and the trust for inviting me here to Puerto Rico. This is my second time on the island. It's a special place with special culture and special people, and I'm glad to be here, and I hope this is the second of many trips to come. I'm going to share with you today 4 vignettes of some work that we're doing. I was so struck by the A, B, C, D, and E framework that I titled my talk and reorganized things a little bit. David and Dexter's framing of the use of those tools, I think, tells us that we're on the right track and how we're thinking about using artificial intelligence, blockchain, cybersecurity tools, and hopefully in the not too distant future, digital twins. Our program has a research and clinical component that is tied to our primary care practice and a small ambulatory health system in Texas A&M University's Health Sciences Center. It serves a 7-county area in Brazos Valley. There are about 30,000 patients that have had encounters in our clinic over the last 3 to 4 years. And the work we're doing sort of blends and integrates research with clinical care. But what that does is it provides us with kind of a learning laboratory to work with real-world data and do implementation science in a clinical setting. My longstanding interest has been in clinical genomics.
While he's doing that, then David, Dexter, and again, just given the right timing, what would you say right now it's the most promising application of AI in precision medicine today? David, I'll give you the floor. And again, just given the time that we have now available in our hands. Go ahead, David.
Promising, it's hard to say. So the people that make the machines, Hologic and GE, these guys have all kinds of AI in their product as the resolutions get better. Like, the way I think about this, our human brain is relatively limited. Like, I think I heard trillions of cells somewhere today, a billion, maybe hundreds of trillions of synapses. But at some point, if you double and triple and quadruple the resolution of these images, your brain simply does not have the bandwidth to process. The reason I don't practice medicine, at least I like to say the reason I don't like to practice medicine is I am medically legally responsible for gigapixel pathology. How is that a reasonable expectation from one industry to another? But what I think is the most impactful use of AI today, and AI, I'll go with the marketing term of ChatGPT, is people are taking their medical records, uploading them into ChatGPT, and being blown away by what this thing is telling them. Hyperbilirubinemia, hypercystinuria, all kinds of very interesting diagnosis, misdiagnoses, and active advice.
And that they can understand it.
And they can understand it. Yeah.
English language for non-medical professionals.
Now, what is concerning is it right? I don't know. But we should probably be looking into this, David.
Well, when you look at the amount of drug discovery, too, going from 40 novel compounds to 400 to 4,000 to 4 million in just a few years with AI, there's more than we can unpack. We need processes to be able to do that. But there's a lot to be unpacked out there in precision medicine.
Yeah, and I think this is perfect timing right now to continue with the dialogue in terms of what's promising and the implementation and the past performance and experience you have had with ABCD and AI. Over to you.
Yeah, thanks so much. And I'll get through this quickly. I'm just going to share 4 vignettes of some of the work we're doing. I'm really looking forward to the discussion. So clinical genomics is a term that some of you may not be familiar with, but basically it's taking genomic information that may come from genotyping, tumor sequencing, targeted sequencing like we do in our pharmacogenomics program, and adding to that information, annotation about the patient experience. Oftentimes that's data from their electronic medical record. Now, in oncology, where I think this is one of the better examples of successful implementation of clinical genomics and precision medicine. In 2003, I got involved in non-small cell lung cancer drug development and had a front row seat to the implementation of precision medicine in this space. And in the 15 years on, between 2003 and 2018, a non-small cell lung cancer patient saw their 5-year survival expectancy go from 10 months to 40 months. So this was a really remarkable improvement in clinical outcomes. And it's improved much since then with some of the new immunotherapies, including some that have become first line for patients that have immune cells infiltrated into their tumors. Sequencing and other high throughput bioanalytic methodologies are really going to make this important in the future. But the clinical annotation piece of the picture, what do we know about the patient and their journey with their disease, is a critical piece of the picture that informs how to use these tools. So the data is fragmented. In oncology, the data lives in the databases of the companies that do the sequencing, or sometimes the pharmaceutical companies that do the clinical trials, maybe the NCI-designated cancer centers that run the trials, and they all have sort of a different complement of data, but they don't have a complete picture of the patient journey. And certainly not the medical record leading up to their disease process. And one of the challenges is what I call the multi-agency problem. We published a paper on this out of a symposium we had in Houston last year, where with health data, the patient has rights to decide how that data gets used, who uses it, and for what. But oftentimes institutional stewards have a role, and sometimes that drowns out the agency or the voice of the patient and how that data is used. You have IRBs, you have university administrators, you have executives in healthcare systems and hospitals that all have a say in how this data gets used. Long story short, it's really hard to move this data across organizational boundaries, geography, and time to get a complete understanding of that patient's health or deterioration thereof. This is sort of another concept paper that we published a few years ago, sort of outlining some of the challenges associated with this agency issue, and it creates frictions in moving this data. So the promise of clinical genomics has largely fell into large companies that do population scale bioanalytic work or run clinical trials because they can grab data through the course of doing their business. It's harder in other areas like pharmacogenomics, where one of our programs works, because the data is fragmented. And pulling all of the agents together to decide whether or not to allow a certain use of data is prohibitively expensive. So we have 4 programs at Texas A&M that are open clinical studies where we're trying to implement and evaluate new tools that solve some of these problems. And all of them are at the nexus of artificial intelligence, blockchain, cybersecurity, and we hope to eventually be able to solve some of these frictions because they all need to be addressed to achieve digital twins. To build a digital twin model of a patient, you need to collect data from a number of organizations across time and across geography to really build a good model. And we can't do that now with current data governance models. So this is just a vignette on an artificial intelligence tool that we deployed in the early days of our pharmacogenomics clinic. In the upper right, you see a chart analysis tool. The black stars are an indication of the problems that this is a composite patient that was sort of a synthetic data set from some real patients in our clinic. The black stars tell you the problems that this patient was having. Well, there was a neural net technology running in the background and a natural language process. This natural language processing technology, this is not an LLM, this is pre-2018, pre-transformer technology. So this is not nearly as powerful as the technologies today, but this dashboard represents sort of a usable, intuitive tool for providers to be able to see the issues the patient is having, and then on the right, you see the phenotypes or side effects that would be expected with the many medications that this patient are on. So with this dashboard alone, one could start to understand the high-dimensional problem of this patient having a lot of medications. Then on the bottom, you see 9 different pharmacogenes. So this patient had 9 genes that had variants that might impact the efficacy or safety of the medications that they were on. So that adds another layer of complexity and some dimensionality on it. And the same sort of AI tools help render these 2 dashboards. So this was a clinical decision support tool to take complex pharmacological information from a knowledge base about drug interactions and pharmacogenomic variants and make it really easy to interpret for providers trying to figure out which medication they should prescribe or which medication may be causing the patient's issue. Now, unfortunately, this is a really interesting story, but this tool got decommissioned, and we're in the process of building something new to replace it. But we have the benefit of more powerful technologies today. So in this particular pilot project, we had one patient we published this case report on early last year. So this patient had a paniculectomy, which means that the abdominal skin had been removed after a gastric bypass surgery. And unbeknownst to the surgeon, that patient had had their dose of Prozac increased before they went in for the procedure. This patient had a severe episode of bleeding, was hospitalized for several days, and it was a real problem. We didn't see this with our tools, but with the information we had in our system, we were able to adjudicate this adverse drug reaction that in part was caused by the change in dose of their Prozac prior to them going in for a surgical procedure. But you can see in the bottom right, there's a lot going on with this patient that involves pharmacogenomic variants, drug-drug interactions, and other things. So in this clinic, we consent people to participate in a research program, and we get 1 year of their electronic medical record data looking back, 5 years going forward, to stitch together as complete a story about their patient journey as we can. And the idea is to put this data onto a blockchain platform and use the tools and power of blockchain to bring agency to all of the stakeholders in that data, the institutional stakeholders, the IRB, and importantly, the patient, and how we use that data in the future. So we're really excited about building the Provenance data platform. This is going to allow us to start to solve the patient agency data and be able to start to move this data across the patient experience and eventually to other clinics and other users that may not be in the same medical record or health system. This is just a schema of the different technologies that we're using in our platform. I won't speak too much about it because I've touched on most of them. Whoops. So this QR code here is a mechanism that a group in Europe used to make a patient's pharmacogenomic test results available to any provider across across country borders and across health systems in a large clinical trial for pharmacogenomic utility that was done in Europe. So we're looking to deploy a similar type of mechanism with a encryption technology company out of the Baylor College of Medicine in Houston to make our patients' pharmacogenomic test results available not only to the people who have access to our medical record, but to any provider that they might encounter, and get simple clinical decision support for folks that may not know how to interpret a pharmacogenomic or know what a star 6 to CYP2D6 variant really means from a clinical perspective. You know, longer term, we envision using the data that we curate on our patients to build models that are predictive of ADR and can examine the data, parse signals out of the data in our electronic medical record to see adverse drug reactions that are otherwise sort of out of the reach of human intuition, and certainly out of the reach of a primary care physician who has 10 to 15 minutes for a patient encounter. Recently, we had a partnership discussion with a large tech company that is heavily into the agentic AI space, and they stitched together a lot of the knowledge bases that you see on the right and some very limited synthetic patient data that you see in the middle to build sort of some prototype models that was more a demonstration of how the plumbing would work for a pharmacological digital twins model. And I was blown away. I think it's, there's a really promising future for us finally to get at the complexity of polypharmacy and a lot of the significant healthcare problems that surround using medications. So in a nutshell, deploying these technologies into our environment and curating, building consensus data models and curating data, hopefully we can build sort of a best practice for a pharmacological digital twin that can be used in the clinic for clinical decision support that is as simple, intuitive, and easy to use as those two dashboards that I showed you at the beginning. We have a really large interdisciplinary team that has been working on these problems, ranging from genomics, medical informatics, bioinformatics, and data science, and I'm thankful to all of these folks. You recognize probably a couple of people. Dr. Ramos has also obviously steered the group and kept us on the right track and off the wrong track along the way. Julimar, who is here, was instrumental in helping us build some of the data dictionaries for our pharmacogenomic data warehouse that's finally been activated and implemented. So I'm glad to be here, and I look forward to the discussion. Thanks for listening to me.
See, as promised, it was going to be thought-provoking. Again, we get great minds in the room, and this is what it takes, right? We want to talk about AI and the influence of what's going to happen next. Now, out of respect for everyone's time, we're not going to go into the Q&A, but I am going to ask the panelists just to give us one final thought in AI and the impact in precision medicine, and are we ready today in Puerto Rico and the country and globally to adopt that? But it will be, again, final thought, 2 minutes. But I also want to give you there was what is it? Cisco 2 months ago did a survey to CEOs and healthcare providers and hospital administrators about AI. And the outcome was clear. 95% of them were extremely excited about AI and implementing. But only 5% thought that they were ready to implement AI. So this is a conversation that must take place, because although AI is here, the infrastructure is needed from policies, from how are we going to impact the patient, and how the clinician is going to adopt AI. So this is the type of conversation, and I do want to thank Lucy and the Trust for really being having that inspiration of having the conversation today, because if you're not talking about it, it's going to happen regardless. So I think this is a type of dialogue and conversation that is very much needed. So I will ask our panelists, again, just a quick take-home message from the three of you, and I greatly thank you, the three of you, for taking the time to share your thoughts and knowledge with us.
I'll give a quick one. So this past year, got to go to AI Med and lead the cyber track. And while there, the head of the AMA spoke about AI. And there were two key takeaways that I really liked. I had seen some things he had written before, that AI is not going to replace doctors. Doctors who use AI will replace your doctor. So those are the things that people might care about. The second part is from something I did this week. There was a major study, 6-year study, that just had results released in the New York Times yesterday from Harvard and from Baylor and from Regents and Gallup and a number, looking at global flourishing, number of countries, 200,000 participants. And when you look at that survey, one of those key things is, of course, health and wellness, well-being, and what that means. It's higher than GDP, gross domestic product, money. That's probably what people care about, more so than what tool they're going to use or what study did what. They care about good care. They care about high tech, high touch, maybe, if they care about the technology at all. But they want what you have in terms of care. And when I see a community like Puerto Rico, and when I see what you can do with this population this size, just big enough, just small enough, there are some incredible opportunities. So hopefully we'll lean into that together and see where that might take us.
Thank you, David.
All right, I can go next. Since Patrick, you just spoke. I think humans are extremely biased towards themselves. Obama announced Precision Medicine Initiative in 2015, and the average Puerto Rican doesn't know what it is. This is the reality. The average American doesn't know what it is. I think that needs to be fixed. First and foremost, marketing has to change. I think 2015 was much too early to discriminate the 10 or 20 or 5% of the 6 billion nucleotides that actually we're talking about here. And that's it. A couple hundred, I mean, a few million nucleotides, but still, you need AI to discriminate that. Otherwise, you're just drawing lines all day, which was the point of my talk. So now we're at a point where we have enough genome sequenced. I mean, how many genomes have been sequenced over there? I mean, a lot. Not in 2015, how many? It's a small number. Much, much more today as the price goes down. So today, just pragmatically speaking, we're in a much better position, technically speaking, to do things with AI. And finally, the representation is a problem. AI today is a supervised sport, and if we replicate the supervision thus far, this is a bad thing. I think places like Puerto Rico, places with money, with development, with the backing of certain forces, should lead the way. Because if you think about how precision medicine works, probably the best example of precision medicine is PCSK9. It's an ethno-specific drug for African American hypercholesterol. How'd they find it? Started out in France or in Europe, like most of these clinical trials, and ended up with some fine mapping in Mozambique or some very derived African country. So what I would like to implore all of you is America is diversity. Puerto Rico is diversity. The whole of America, I mean, look at China, look at Europe. These places are relatively monotonous. So the only hope to actually discriminate some of these pathways is in places like this, where you have the kind of diversity to go look. So you don't have to go to Africa and China and Spain and all these different continents, because they're all right here in places like Puerto Rico. So thank you.
Thank you, Dexter.
Yeah, so the one take-home comment I would leave you with is applying AI to healthcare, and particularly patient or case-level decision-making, is going to be hard, much harder than other domains of AI application, because patient data is so sensitive, privacy preservation is so important, and the regulatory and ethical constraints are a challenge. That said, I think blockchain technologies are going to help unlock a lot of those issues by making a lot of those data governance processes digital, real time, and in parallel. And just a quick shout out to our collaborator Genio, who has funding from National Institute for Genomic Research, NHLBI, and APBIIH. Their overarching goal is to build a new data fabric. What do they mean by that? Well, it's kind of like the blueprint or the plumbing or the architecture for this new form of data governance that we need to move data through the data ecosystem so that it can be used to do models that are relevant to patients, relevant to the systems considerations, not just the biology of disease, and relevant to social determinants of health and other factors that we know are important in assessing outcomes and assigning the right interventions, medications, et cetera. So that's, I think it's going to be really hard until we get a new data governance model in place so that we can move data around. But patients, just one last anecdote, it costs more to store a human genome sequence for a year than it costs to do the sequencing. Who's going to pay for that? Well, data is currency. The data can pay for that. And I make a prediction. In a decade or so, maybe a little more, maybe a little less, that's what is going to happen. That's going to be part of the new model. Thank you very much.
Oh, excellent. Thank you, Rick. And by the way, the data storage needed for AI is 26 times greater than it takes from one nuclear reactor. That's just a proven factor. Now, Dr. Ramos this morning, I think, summarized everything for us in an introduction for AI. As I quote, AI is the solution for the total integration that will enable precision medicine. So I think that wisdom, I think, complemented the conversation today. Thank you all. Thank you to the panels for the insightful contributions and the valuable time today. Now, for all of you, it's been a real pleasure. The audience, you've been just wonderful. Now, I would like to leave you, of course, with a final thought from Albert Einstein. The measure of intelligence is the ability to change. And my question to all of you as you drive home today or go back to your hotel room, is our healthcare system, our clinicians, our patients ready to adopt this change called AI? But I don't know. If you want to learn more, ask the ChatGPT, then you might get an answer. You have a wonderful rest of the day. Thank you again.